which is from the cattle and African, the human. 2004, 9 million cases, new cases, 1.5 deaths per year. 1/3 of the population have latent TB, of the world population. It's more common in the post and lower socioeconomic areas, and we often found with HIV coincidentally, and it's coincidentally most of the time associated with HIV. Mycobacterium bovis comes from non-sterilized milk. Mycobacterium tuberculosis, inhalation of aerosols. Once organism in the alveoli, macrophages and lymphocyte will uptake the organism, and then the epithelioid and Langerhans cell will cause a collection and tuberculous granuloma, which contains large multinucleated cells, as you know, what causes the granuloma. Next. Many tuberculous granuloma aggregate, they will cause, so granulomas will make something called primary lesion Gons focus, pale yellow caseous nodule, so caseating necrotizing granulomas, as we know, is different from non-caseating, which is more of sarcoidosis. Okay, few millimeters to 2 centimeters at the periphery of the lung, then spread organism to the hilar lymph node. With involvement of the hilar lymph node, they will call it Gone complex. Okay, so first Gone focus, then Gone complex. When the hilar lymph nodes are involved, then eventually, as a protection, the body will contain this granulomas and will cause calcification to contain the infection within that. Okay, so and eventually will be called primary complex of Franke. So we'll see lymph node plus a calcified, probably Gone focus. Okay. Then encased in a fibrous capsule and calcified lesions indicate the latent TB. Next. This is the granulomas. There is a lot of multinucleated large cells and caseating. There is a lot of necrosis within the center where the black arrow is there, with a lot of macrophages and multinucleated giant cells as well. Next. And this is the Gone focus. So the Gone focus, then the Gone complex, when the hilar is involved, then will be calcified, and if there is a hematogenous spread to the adjacent parenchyma, you will have primary TB and might be adjacent or as well spread to the pleura and causes TB, pleuritis, and pleural effusion. And we'll see this is the Ranke complex calcified, the Gone focus, the Gone complex, and the Ranke complex calcification, which leads us that the patient has got a latent TB. Next. We'll talk about latent TB in a few seconds, a few slides. If immunity not developed, lymphatic and hematogenous spread will occur at different organs. Okay. When we test for the TB, there is a tuberculin skin test, which is a delayed hypersensitivity reaction. It's a type 4 hypersensitivity reaction where there is a deployment of T cells. It's like the contact dermatitis thing. So often when we do that, we need to read it 48 to 96 hours, but ideally 72 hours and above. Okay. 10% of primary infection develop TB disease, 10% of half of them in the first 2 years after infection. Next. So factors that increase the risk of the TB is the extreme of age, either too young or too old. Okay, we have to remember that. Third generation immigrant from high prevalence countries. First generation اللي أجوا الناس, for those who traveled, Indian for example, South Asian that went to Europe, the first generation, they have the highest prevalence. Then that will come down with their offsprings. تمام. Close contact with a smear positive TB. يعني if you have a close contact with a smear negative, it's less likely, but with a smear positive still, which means that he's producing, there is a lot of TB in his sputum, that increases the risk. Overcrowding, prisons, collective immunities, homelessness, houses, home cares, nurseries, all of these. Chest X-ray evidence of self-healed TB, primary infection of the last year, smoking as well increases, especially type of Indian smoking. Immune suppression, HIV, anti-TNF, that's quite important. High dose of steroid and anti-CD20 like rituximab, and all of these you should test for latent TB before you give these patients, because there is a high risk of there will be a risk of reactivation of the TB. Okay, malignancy, lymphomas, leukemias, diabetes, chronic kidney disease, scoliosis, gastrointestinal disease associated with malnutrition, all of these are at risk of TB. So malnourished areas are at risk of developing TB. Deficiencies of D and A, next please, and recent measles. Time of infection 3 to 8 weeks. Primary complex positive tuberculin test. Often it takes 3 weeks for tuberculin test to be positive, and sometimes longer than that. 3 to 6 months meningeal, miliary, and pleural disease. Up to 3 years gastrointestinal, bone, joint, and lymph node disease. Around 8 years renal tract disease. From 3 years onward, post-primary disease due to reactivation or reinfection. Primary pulmonary TB refers to the infection of an previously infected TB. So a patient who is not known to have latent TB, so we said it's primary. If a patient has a latent TB and he has an activation, we call it secondary. Okay? Self-limiting febrile, so it will usually present like a prodromal symptoms, flu-like symptoms, okay? Flu-like illness, hypersensitive progressive infection. Next, please. Okay, influenza-like, skin test converted in 4 to 8 weeks, and primary complex disease. Lymphadenopathy, hilar, might be unilateral, hilar lymphadenopathy, X-ray, just finding paratracheal or mediastinal hilar. Collapse of the right middle lobe, because of the consolidation either or the mucus plug. Emphysema, cavitation rare, but usually it occurs on upper lobes more in aerated areas. Pleural effusion, miliary TB, meningitis, and pericarditis. Hypersensitivity, that means it's a reaction to the TB, the pulmonary TB, but there is no infection, active infection there. So erythema nodosum, dactylitis, and conjunctivitis, like an reactive inflammations to the infection within the lung. That does not mean hematogenous spread there, but can spread there. In the miliary, sometimes you see spread. But this is our reactionary. So the infection is in a site, and the reaction is in a different site. Okay? Toxicide ya jama'a. Any questions? Miliary tuberculosis is blood-borne, massive dissemination, all body, 2 to 3 week fever, night sweats, anorexia, drenching night sweats. That's what we ask about the B symptoms. With our history, weight loss, dry cough, headaches, meningitis query. You don't know if he's having meningitis, TB meningitis. Auscultation normal, and crackles. انتوا اخذتوا حضور وغياب صحيح؟ كل واحد يكتب الحضور وغياب للجروب تاعه بس اللي حاضرين. Okay. Crackles in the advanced disease, fundoscopy choroidal tubercles, that's what we are talking about when there is a miliary TB that might spread, and the tubercles, granulomas, might be by the fundoscopy in the posterior chamber of the eye. Okay. Chest X-ray, fine 1 to 2 millimeter lesions, milk seed زي حبوب زي السمسم بتلاقيهم منثورين على الشست. Yes, that's what I was talking about. Yes. Anemia, leukopenia, when there is hematogenous spread, there will be a bone marrow involvement and suppression. Cryptic miliary TB, which means unusual presentation in old age. Next, please. Next. Cryptic TB in old age, more than 60, usually it's يعني يفترض انه after 60 it should not see that, but sometimes it's in. Low grade pyrexia should be considered sometimes induced with unknown fever of unknown source or of unknown origin. Patients who present with fever of unknown origin, unknown source, مش عارفين شو ماله, negative tuberculin test, we should consider that if we rule out many of the list, like brucella, Malta fever, and EBV, and a lot of stuff you should thinking about when you think about fever of unknown origin. Next, please. And here you can imagine that they did a PET scan to see if that they found that the lymph node, they are glomeruli, and they can target one of these lymph nodes, take biopsies, the safest, the most nearest, they can take biopsies there and send it to the lab. Post-primary TB disease, exogenous new infection, endogenous reactivation of primary, frequently pulmonary in the apices of the lung because of it's an aerobic organism and loves the air, so it goes to the most aerated areas of the lung, which are the apices. Onset insidious and take several weeks, post-primary pulmonary. Next. Systemic symptoms, as we know, fever, night sweat, malaise, and this stuff. Chest X-ray, ill-defined ossification in one or both upper lobes, plus consolidation, collapse, cavitation, and occasionally caseous lymph node drain, tuberculous pneumonia. Pulmonary TB, as we said, this is the presentation. Chronic cough, often with hemoptysis, sometimes without. Pyrexia, non-hemorrhage, non-origin, that's what we were talking about. Unresolved pneumonia, exudative pleural effusion, asymptomatic weight loss, general spontaneous pneumothorax. So unresolved pneumonia, you should think about either obstructive pneumonia, number one, malignancy, the treating pneumonia that's unresolving for 4 to 6 weeks, that changes on the X-ray. And the other thing, think about the TB as well. Chronic complication, massive hemoptysis, if there is cavitation and erosion and the underlying bronchial artery is eroded, so they might present with massive hemoptysis, which will be late, very late presentation. Core pulmonale, fibrosis, emphysema, atypical mycobacterial infection, aspergilloma, where there is a cavity to reason another, whether TB or an old infection or sometimes staph pneumonia, severe staph pneumonias, BVL secreting staph, BVL, Benton Valentine toxin secreting staph, they might leave cavitations, and whether there is, whenever there is a cavitation, there is a risk of developing aspergilloma, which is a type of fungal infection where there is a humidity and lack of, there is no tissues and no immune cells there, they might develop aspergilloma. So old healed TB with cavitation patients might develop aspergilloma, not to forget that. Lung pleural calcification, obstructive airway disease, bronchiectasis, bronchopleural fistula. Non-pulmonary emphysema, anesthesia, laryngitis, enteritis. Sometimes we might miss, or we think that patient might have Crohn's, but this is due to right iliac fossa mass, but it will be enteritis and ileitis, and it will be granulomas, the TB granulomas. So it might mimic Crohn's as well. Amyloidosis and Ponset polyarthritis. You can see that, yeah. Next, please. Cavitation, consolidation, pneumonia, bronchial. If you come back, just I will show them. So next, a previous slide, please. So you can see that there is pleural effusion, and this is loculated pleural effusion, probably emphysema. And if there is, the emphysema goes toward to the chest wall, and might cause something called emphysema anesthesia. ممكن تشوفوها ممكن ما تشوفوها ممكن مرة واحدة تسمعنا بالعمر. Okay, next. Cavitation, differential diagnosis, pneumonia, lung abscesses, lung cancer, whatever you can mention, infusion, so differential diagnosis for cavitation, you think about pneumonia, lung abscesses, lung cancer, cavitatory lung cancers, infarction post-BE, GBAs, progressive massive fibrosis TB as well, consolidation pneumonia, bronchial pneumonias, carcinomas, and pulmonary infarcts. So I might just stop in this for a sec. Why consolidation? They put bronchial carcinoma as differential in the consolidation. Do anyone knows why? Why consolidation collapse? They put bronchial carcinoma in the differential. What does that mean? Because sometimes bronchoalveolar carcinoma might mimic the pneumonia, because bronchoalveolar carcinoma invades the airways, it walks with the airways, unlike the regular small cell or the squamous or the adenocarcinoma. It likes lesions and nodules and masses. It walks with the alveoli, and because it's bronchoalveolar, they have goblet cells, they have a lot of glandular cells, and the patient will keep secretion and spitting a lot of phlegm that's often clear phlegm. And you are treating that pneumonia, and this pneumonia is not improving, and the CRP is not improving. Then you realize that when you treated him for 3 to 4 weeks and he's not improving, you realize that this CRP is elevated because of the malignancy, and you do CT, you discuss it with MDT, take biopsy. Some of them, they have bronchoalveolar carcinoma. So make sure not to miss non-resolving pneumonia. Think about malignancy number 1, okay? Miliary diffuse shadowing sarcoidosis malignancy. So any patient who comes to you and you think that he might have sarcoidosis, lymphadenopathy, and you should rule out number 1 TB, because TB mimics sarcoid. And the treatment of sarcoid depends on the stage 1 or 2, sometimes just you watch. Stage 3 and 4, you have to give steroid. So if you give a patient with a steroid and you did not make sure that he is not TB, then you would kill him. Okay? So any part of the workup for sarcoidosis is the TB. And if the patient, sometimes when you do biopsy, that's interesting, and you do a biopsy, you find non-caseating and caseating granuloma. Treat the caseating, treat the TB, and the whole picture will improve. Next. Clinical features of extrapulmonary disorders accounts for 20% in HIV negative, and we often see it more in HIV positive patient. Lymphadenitis, cervical, mediastinal, axillary, inguinal, and supraclavicular. Often they mated, painless, mobilized, fluctuating caseation, then liquefaction, then probably they will cause an abscess and sinuses and collar stud abscess. Most common cause by Mycobacterium avium complex, which is a non-tuberculous mycobacterium. So there is Mycobacterium tuberculosis and non-tuberculous mycobacterium, or Mycobacterium avium complex, and we often see it more in the HIV when the CD4 is less than 200. Surgery is rarely required. Zaman can surgery is treatment, but now it's just we have anti-tuberculous management. So how the extratype TB is affecting, we mentioned headache, nausea, vomiting, meningitis, pericarditis, pleuritis, cranial nerve pulses, facial pulses, bulbar involvement, constrictive pericarditis, exudative ascites, mesenteric adenitis, everything. It can affect everything. Psoas muscle abscesses. Next. Gastrointestinal, upper GI is rare, but ileocecal, as we said, 50% of abdominal TB, 30% acute, fever, night sweat, weight loss, right iliac fossa pain, palpable mass. Think about the inflammatory mass like in Crohn's, thickened wall, ascites, barium enema, narrowing. Differential diagnosis might be developed tuberculous peritonitis when there is a spread invasion from that mass to the peritoneum. And when you do laparoscopy and do biopsy, you find white tubercles. Next. Pericardial effusion, constrictive pericarditis. The same, usually the general malaise, the B symptoms, we see that. We have pulsus paradoxus, raised GVB, and in the constrictive pericarditis, how we diagnose it, apart of it being TB, what's the cause of the constrictive? Sometimes when they do the echocardiogram first, you look if there is thickening, and the CT, and the most helpful usually is right side hard cath, or when there is an equalization in the chamber pressures and all the pressures in the chambers, equalization within the chamber, the two chambers, that means that the patient might suggest of constrictive pericarditis, can't contract or diast, or can diastole even well. They have pulsus paradoxus, raised GVB, and ascites because of right-sided effusion, right-sided involvement. Raised GVB, third heart sound, atrial fibrillation, calcification 25%, sometimes you see in the CT. Diagnosis, radiological, clinical echo, and the treatment, you give anti-TB and steroids. So there is two things you give steroid in TB management. And TB meningitis and TB pericarditis, not to forget that, when to give steroids. Part of that is just the anti-TB. Next. General central nervous system meningeal involvement, rapidly fatal, bone and joint disease. Spine, most common site is Pott's disease, chronic back pain, lower thoracic lumbar spine, where there is an abscess in the vertebrae. Discitis, then kyphosis, paravertebral and psoas abscess are quite common. CT MRI will show you, it's more than enough with IV contrast. Joints, frequently hip and knee. But I have seen case that just 2 days, he come, probably I assume he was discharged a week ago from the hospital. He's not a TB, but sometimes it happens. That he comes with a mid-thoracic pain, CT IV with contrast. 2 days before I saw him, it was negative. Then I asked the orthopedic surgeon, shall we do an MRI? He said, yeah, what about a whole spine MRI with contrast? Just less than 24 hours between the images. And the MRI showed the collection, an abscess, which is weird, to be honest. We should be able to see that collection in the CT. I don't know what was going on, but it wasn't TB. Onset erythropathy is immunologically mediated that resolves within 2 months of starting treatment. Again, it's a reactive, like an immune reconstitution. Pott's disease, hematogenous spread of the TB to the vertebrae, abscesses, discitis, then the kyphoscoliosis. Next. Genitourinary, fever, night sweats are rare, so sometimes we do not find the B symptoms there. Mildly symptomatic for many years, sterile biuria, hematuria, dysuria. In women might cause infertility, endometritis, salpingitis, and male epididymitis, and prostatitis. Diagnosis of TB, unexplained cough more than 2 to 3 weeks. Typical chest X-ray requires further investigation. Direct microscopy. We do the Zinn-Nelson and the rhodamine stain, and you can see them under the microscope, under the fluorescence microscope, like that. Next. Confirmed by the culture for low numbers, 10 to 18 to 100. And the problem is it takes 4 to 6 weeks. In 6 weeks, in Lewis-Stein, Jensen media, and Middlebrook media, it takes 4 to 6 weeks. Both of them, they are solid media. Faster method, the Bactic system, takes 1 to 3 weeks, which is a liquid medium, which is a modified, basically, modified Middlebrook medium that contains starch, potatoes, a lot of things that will help, but it's a liquid medium, 1 to 3 weeks. Nucleic acid amplification, BCRs, drug sensitivity, especially in HIV positive, RBO gene detection is mediated, because that's important, because when we talk about, we will talk about TB resistant, multi-drug resistant and resistant, we have resistant to isoniazid and rifampicin. Then we'll talk in the basic. So this is typical fluffy infiltrate with cavitation and multiple upper lobe airspace shadowing. This should raise your suspicion for query TB. The first thing you do, probably, if he's coughing, to put a mask and to do a CT, and then you do TB workup. Next. This is a positive Zinn-Nelson stain, AFP. Next. So, specimens for the pulmonary TB, we got the sputum. The sputum, either if the patient is expectorating, often we ask them to give us a daily, early morning sputum sample for 3 days, if not 2 days. If he is not bringing, either we do hypertonic saline induction of the sputum, or we do bronchoscopy, do washing in just saline, or do BL, bronchoalveolar lavage. And the difference between them, when we go to the targeted loop, whatever we want, we have 3 syringes of Salem syringe, 50 cc saline. You ingest slowly and you suck with your hand without the suction, and you see how the return. And this is called the BL. So the BL is more fluid. The washing is just 10 to 20 cc, and you suction them with a suction, rather than with your hand doing apply a negative pressure. Gastric washing, especially in the children when they swallow their sputum as well. Extrapulmonary fluid examination, whatever you can send it to the culture and the AFB, pleural, ascites, pericardial, whatever. Tissue biopsy, sometimes when the patient with a pleural effusion and you have a suspected TB and you think about an extrapulmonary TB, what we do either you do therapeutic aspiration and you send for BCR and blah blah with the beta and AD deaneminase. The better thing is to do a closed or open, whatever, but closed pleural biopsy. So which is good when you have pleural fluid. Or if you have the fancy of something called medical thoracoscopy, which we do just an opening, 2 centimeter opening with a semi-rigid scope. You go there within the pleura with the fluid. You take biopsies and you suction fluid and you send both of them. Then the yield will be very high for diagnosis. Diagnostic test, tuberculin test, BBD, Mantox test, whatever you want. They give a 0.1 ml intradermally of tuberculin, purified protein derivative for the tuberculin. Then we read it after 72 hours. Stains in Nelson nucleic acid, we mentioned that. Pleural fluid adenosine deaminase, which is specific. And the response often 5 to 10. And when we can discharge the patient, or we say the patient is no longer infectious after starting anti-TB, anyone knows? So when we can see or can say that the patient is not infectious after starting the anti-TB. Patient comes with a cough, diagnosed him with TB, started him an anti-TB. When you can send him home safely to the community. After 2 weeks. Okay. Baseline blood, full blood count, CRP, SR, UNE, and lift. Next. Management of TB chemotherapy, intensive initial rapidly reduces the bacterial population, continuation maintenance phase, then start the treatment of smear positive, smear negative with chest X-ray changes, no response to standard antibiotics. So thinking about that. Quadruple therapy, treatment is usually 2 months of quadruple therapy, isoniazid, rifampicin, parazinamide, and ethambutol daily for 2 months. Ethambutol can be omitted if there is a side effect because of causes eyesight problems and retinitis and eye problems. Followed by isoniazid and rifampicin for another 4 months, total of 6 months, if the patient is not known to have and the test did not show a multi-drug resistant TB. Okay, ethambutol can be added and streptomycin might be added. INH or isonicotyl hydrazine means isoniazid. Next. 6-month therapy is adequate for new cases. 9 to 12 therapy in HIV positive, drug intolerance or when a second line agent is used. Sometimes when there is a drug resistance, especially in isoniazid. When we omit isoniazid and if there is isoniazid resistant, we use second line and then we have to extend the therapy. Meningitis, 12 months, probably pericarditis is the same. Pyridoxine is given to reduce the peripheral neuropathy associated with the isoniazid, so important. That comes usually with a tablet, 1 tablet, so vitamin B6 given in the pregnancy and malnourished, but we can give it, but it's typical now in the guidelines for all patients, even not malnourished. Patients become non-infectious in 2 weeks. Treatment home or hospital isolation of certain diagnosis, multi-drug resistant equals culture positive after 2 months. So if we still isolating the TB after 2 months, is multi-drug or treatment failure. Baseline, we should do baseline liver function because virtually all of them they are hepatotoxic, but they should not do liver damage, and liver damage is rare. Ethambutol affects renal function, mainly HIV. Corticosteroids should be given pericardial, meningeal, and other areas to reduce hypersensitivity. Surgery in cases of massive hemoptysis and BIEMA loculated, then you ask for the thoracic surgeon to come and to do the VATS, video assisted thoracoscopy, and to remove them without BIEMA. Otherwise, the lung will be entrapped, and after 6 to 8 weeks, unlikely if you even refer him to surgery, the lung will re-expand. Okay. Assessment after 2 to 5 months, if still positive, treatment failure. Next. So we have multiple things, 2 months of quadruple and 4 months of twice, 2 months of quadruple and 2 months can use the ethambutol as well. In some countries that have high level of isoniazid resistant in new patients. That's why when we use, and we can extend as we said if we use a second line agent. Dosing daily frequency is the optimal, but we have another formulation that can be given 3 times a week through something called directed observed therapy. في بعض المرضى بيروحوا لهم كانوا يروحوا لهم زمان, they observe them when they eat, they took the drug in order not to develop resistance. شباب, we almost finished the melatonin. Okay, because one of the causes for resistance, either you live in, the patient lives in resistant prevalent area with TB, a TB resistant prevalent area, or patient failed treatment failure, or he does not take his medication before. So this will increase the risk of resistance. Okay, next. Major reactions, isoniazid cell wall synthesis, I can leave this for you, and the side effects and how they act, DNA inscription, and streptomycin 8 nerve damage, which means cause vertigo and labyrinthitis, might affect causes ototoxicity, retrobulbar neuritis, which affect the eye. And when we start on ethambutol, always we do baseline eye testing, then we do after 2 months, then after 6 months by the end of that. Next. Control and prevention, detection of latent TB, tuberculin or test or HIV test. What's the difference? Tuberculin, as you said, is an intradermal thing, just one brick. HIV test is a gum with a 5 the gun on the done on the firearm, on the flexor, with the five needles. Okay. Anyway, and now both of them, they are replaced by IGRAS, interferon gamma release assays, the quantiferon gold that we probably you heard about it. When the T cell sensitized the mycobacterium antigen, not present, and the BCG and the opportunistic mycobacteria, because patients who have BCG vaccine, they will be they will have false positive tuberculin test, and it might be positive for up to 17 years. And the thing is, the BCG does protect for kids from, I think, meningitis, and does not protect from pulmonary TB. So even if the patient is vaccinated for BCG, he might develop pulmonary TB, because the BCG it protects against more of TB meningitis. Okay, so this will measure the interferon gamma, the amount of the interferon gamma that's released by the sensitized T cell to the TB antigen. Okay, and they quantify it. So this will give you a hint about that. Treatment of the latent TB, rifampicin isoniazide for 3 months, or isoniazide in its own monotherapy 6 months. Next. That's the TB, the difference between the HEAF test, the Mantox test, when we read them. As we said, the Mantox test usually 48 to 69 hours because it delayed hypersensitivity reaction type 4, and ideally 72 hours after. And we have we measure the duration rather than the erythema, the duration, and it's less than 5, less than 10, it's more than 5, 10, and 15. It depends on the risk factors of the patient itself. False negative and severe TB, miliary TB, Mantox is negative. Newborn, elderly, HIV less than 200, recent infection, immune suppressive malignancy, sarcoidosis. All of these, they called something called energy. Energy, which means when you do the test and the test is negative, the body is not responding, is not doing the delay test, the delay hypersensitivity, called energy. Remember that. Sarcoidosis patient, كيف نفرقهم when we do the BBD, they have energy, they will not react. Next. And this is the durations and the HEAF test. So you can see that the HEAF test is 6 needles within the gun, and they measure that. And it's grade 1, grade 2, grade 3, and you will see next. Directly observed therapy 3 times a week. TB and HIV are close links, so all TB with patients should be tested for HIV. Here in our country, you have to take, either you tell them or not, but outside you have to take a permission, you have to take a consent. It shouldn't be a written consent, but you have to take a consent that the patient, I am going to do an HIV for you testing. إذا عملتها بدون ممكن يشتكي عليك ويضيعك. Okay, drug resistant TB, multi-drug resistant, there is a resistant to rifampicin and isoniazide, xeno-resistant, multi-drug resistant plus quilinone, because we use moxifloxacin sometimes, and we use some respiratory quilinones as a second line and the treatment of the TB, plus one of the second line injectable like streptomycin. The others, factors contributing to emergence of drug resistance, as we said, drug shortages, poor quality of drug, lack of appropriate supervision, that will cause resistant transmission of drug resistant, and prior anti-TB or amikacin, kanamycin, gentamicin can be used. Next. Vaccines, BCG is a life attenuated vaccine, should not be given to the pregnancy and pregnancy. Intradermal, highly immunogenic in children in high risk group, UK safe vaccines, not given to immune compromised or pregnant. Prognosis of TB cases, cure of majority of the patients, less than 5% relapse, untreated are infectious for 2 years, 25 they die within the first year. Opportunistic infections, atypical, non-NTM, Mycobacterium avian complex, severe HIV, immune compromised with the chronic lung disease such as COPD, bronchiectasis. So chronic lung disease, they are liable for non-NTM. Wherever you go, إذا رحتوا برا راح تشوفوا the chronic lung disease is more outside, the bronchiectasis is highly more. You will see non-NTM always there. You can isolate. Radiologically, lower zone, more nodularity, slowly growing organisms, and rapid method for detection, BCR and RNA gene sequencing. Next. We have the pulmonary that affect the pulmonary Mycobacterium caenisii, Mycobacterium avium, and sometimes it's not written here, Mycobacterium chimera as well is isolated from the sputum. A lot of patients. Lymph nodes, you can read through that in your own, but you have to know that there is tuberculous and non-tuberculous, and these are the treatment of these is long, usually often 18 to 24 months. Sometimes it's long, and it's not easy to treat. Next. And often opportunistic, high TB prevalence areas, Mid and South Africa and South Asia. Next. Any questions? Any questions about the whole lectures? No, you mean calculation? Yeah, I think so. It's easy. كلهم عبارة عن 4 equations, 4 equations, not that much. For the ABGs, I'm saying. I'm not saying for the... I wouldn't, to be honest, we wouldn't ask about Kortkov or estimation or calculation of GFR. No, we wouldn't do that. But ABG, we would ask you about if it's compensated or not. We need to understand that you are understanding what's going on. Okay? Thank you. The slide that, the questions from the slides, they are